Hi, everyone. It looks like we have a pretty good number here, around 31 people. So I'm going to go ahead and kick us off and thank you for joining us today for such an exciting event. My name is Nicole Figueroa, and my role actually is at Michigan Medicine. And I am the nurse leader for well-being and diversity, equity, and inclusion. And I have the great honor of being part of the LGBTQ plus Nursing Leadership Society and hearing and working amongst some amazing leaders at the School of Nursing around a lot of this work. And I have the great honor of introducing Charlie, who will be our moderator today. So let me introduce Charlie really quick. So Charlie Linus, let me pull up my notes here, Charlie, so I can give you all the kudos that you deserve. So Charlie is, I apologize, guys. Of course, there we go. Charlie will be our moderator today, and Charlie is a junior nursing student and a nursing assistant at Michigan Medicine. He is interested in pediatric emergency and ICU nursing and providing trauma-informed, inclusive, family-centered care. He is a founding member of the LGBTQ plus Nursing Leadership Society and is committed to enhancing LGBTQ patient care. He is very excited for today's webinar topic and to learn more about supporting transgender clients. And so I will hand it off to Charlie to take us away, and very excited to be here. So Charlie, the floor is yours.
Thank you so much, Nicole. We're really happy to have you here too, and with us at all of our meetings. So today's topic is about caring for transgender clients. And oopsies. There we go. We're just going to start with some introductions about our organization and what we do, and we'll give you some background information about LGBT nursing care as it stands right now. And then we'll hear from our guest speaker, Sarah Weiner, who's a social worker over at Michigan Medicine. And we'll have some time at the end for Q&A, and we'll give you some resources as we head out. So LGBTQ Nursing Leadership Society is a new organization starting at the School of Nursing here. We are looking for undergraduate and graduate nursing students, and we are very open for any leadership positions that you might be interested in taking on. And we can also provide you with meetings with a mentor and connect you with faculty at the university. So hopefully we have some things that interest you. We really are looking for people who can contribute to our goal of creating a more inclusive nursing curriculum. So also on this slide, we have a QR code or a link. It's just the registration form for this event, helps us keep track of who all is here. So if you are able to fill that out, if you didn't get a chance to fill out our interest form before the event, definitely just pop your information in there. And it will be at the end too, so don't worry if you can't get to it right now. So we'll start with just a quick review of terms that you might hear throughout this presentation. So cisgender refers to anyone whose gender is the same as the sex they were assigned at birth. Transgender would be someone whose gender does not match their assigned sex at birth. And then non-binary would be someone whose gender doesn't fit into the man or woman category. And then intersex would be someone whose assigned sex at birth is not distinctly male or female. So you just might hear those throughout this presentation. And then just a little bit more about terminology, just trying to keep you guys up to date. If you're not quite sure how to apply some of the terms that you might hear. So instead of saying a female who identifies as male or identifies as a man, it's actually more correct to say a male who was assigned female at birth. Instead of saying he or she walks his or her dog, you can just say that they walk their dog. They, them pronouns are a really easy, gender neutral way to address people, and it's good to practice. And then instead of saying she is a transsexual, that term isn't really used anymore. You would rather say she is transgender. Of course, always ask your clients or anyone you're interacting with how they identify, because they might use terms that you might feel like are inappropriate or terms you haven't heard of. So just always ask. So we're going to talk a little bit about transgender health outcomes. Right now, there are approximately 1.4 million transgender people in the United States, so it's a pretty big population of people. And this map here just shows kind of how it's distributed. So you can see there's a lot in California, surprising amount in Georgia. Michigan, there's not too many, but there's not too few right in the middle. And so, you know, if you're working, living in Michigan, you're definitely going to happen across these patients in your care. So transgender clients are 6 times more likely to have a mood or anxiety disorder, 3 times more likely to be prescribed antidepressants and anti-anxiety medications, and 6 times more likely to attempt suicide. So these populations are at really big risk for poor health outcomes, and it's something that we can change by understanding the correct ways to treat them with respect and really elevate the care that they're getting from us. And so these are just some barriers that transgender clients face when seeking healthcare. By far, the biggest barrier is lack of access due to a shortage of providers who are knowledgeable about providing trans care. So doing things like attending these events is a great way to start to break down that barrier, educating yourself and educating others. Other barriers that they are likely to face is financial barriers, discrimination, lack of cultural competence, and health system and socioeconomic barriers that we see in other populations as well. So now that you have a little bit of context, I don't want to wait any longer. I'm very excited to have our guest speaker from Michigan Medicine here, Sarah Weiner. Sarah Weiner leads the mental health component of the Child and Adolescent Gender Services at CS Mott. In this role, she provides behavioral health services to transgender youth ages 3 to 22 and their families. In her years at Michigan Medicine, she has played a role in coordinating the administrative aspects of transgender health within the health system, participated in policy development to ensure equitable and inclusive care to trans people, and provided education within and outside of the system to build gender-related competencies among healthcare providers and staff. She frequently presents on transgender health topics, both domestically and internationally, and a book chapter she co-wrote on access to medical care for transgender youth was published last year. Congratulations on that, Sarah, and we are really grateful to have you here. We are going to dive right in with the questions, if you're ready, Sarah.
Absolutely, I'm so happy to be with you.
Golly, not very Zoom friendly, am I? All right, here we go. So could you just start by telling us a little bit about the types of gender affirming care that are available at your clinic?
Absolutely. So again, thank you all for having me. My name's Sarah, she, her pronouns, talking about trans health and the experiences of trans people in the healthcare environment is probably my favorite topic in the entire world. So I appreciate the opportunity to speak with you all. And we have several prepared questions that people submitted ahead of time, but I'm really hoping that we will have time at the end if folks have questions that we don't get to cover in the slides. So my fingers are crossed. If you have additional questions, definitely, hopefully you'll be able to ask them. All right, so gender affirming care. There are many options for people. Some of the care options are most applicable to youth, and some of the options are for people who are adults, and I'll talk about all of them. So starting with youth, for pre-pubertal kids, no, I should say for kids who are at the cusp of puberty. So Tanner 2, those kids, if they are identifying with a gender that's different from their sex, we can prevent the puberty of their sex by intervening with puberty suppression, drugs like Lupron, Vantis, that sort of thing. So that's positive because a child won't begin menstruating if they identify as a guy. They won't begin developing breasts if they identify as a guy. For children assigned male at birth, and we are able to block the puberty, their voice won't drop. So there are lots of benefits to blocking puberty if we know that a child has gender dysphoria and does not identify with their sex. For kids who are post-pubertal and for adults, I guess I should say, hormones are a possibility. So that is estrogen or testosterone. Estrogen will, of course, feminize a body, help a person grow their own breasts, make skin softer, redistribute the fat in the body. Testosterone will lower a person's voice, will promote facial hair, body hair, again, redistribute fat in the body to a pattern more consistent with a cisgender man. Lots of changes that you can anticipate based on the puberty of cisgender boys. So those are some major gender affirming interventions. And then there is, of course, surgeries. And what I want to say about all of this is that not everybody wants or needs gender affirming medical care. Care does not legitimize a person's identity. It doesn't make someone trans. So if a person doesn't want to be on hormones, great. They are just as trans as someone who does want to be on hormones. Similarly with surgery, lots of people are not interested in surgery, and that is totally okay. People's decisions about their body and what medical paths they choose are different for everyone, and there's no right or wrong. So in terms of surgeries, there's everything from facial feminization surgery to top surgery, otherwise known as mastectomy, to genital surgery that includes vaginoplasty, phalloplasty, metoidioplasty, orchiectomy. There are lots of different gender surgeries. And oftentimes, binary trans folks are interested in interventions that will help them look and sound more like the gender that they identify with. But oftentimes non-binary people as well might be interested in some of these interventions as well. So you just have to really ask an individual what their goals are, remain curious, try not to make assumptions, etc. I hope that answers that question.
Yeah, that's fantastic. Thank you. So this, you kind of dove into this a little bit, but if you had anything to add about if all trans people receive the same kinds of care.
I got ahead of myself, didn't I?
That's great, yeah.
Yeah, so it's a terrific question. I can just emphasize this more, that there is not a one size fits all to trans healthcare. If you had a group of 100 trans men in a room, or 100 trans women in a room, or 100 non-binary people in a room, they might have 100 different feelings, needs, wants when it comes to medical intervention, or like 50, you know. I guess what I'm saying here is there is not one path that every trans man takes, that every trans woman takes, that every non-binary person takes. Care is very unique. A person's goals are unique, and that we, as healthcare providers, are interested in just helping a person reach their own unique goals.
So if you could tell us a little bit more about that process, then, if there are eligibility requirements that they have to meet before they can get some of those treatments.
Absolutely. So the process for receiving medical care can be onerous. And Charlie touched on this in some of the early slides. that access to care is probably the number one barrier for trans folks obtaining gender affirming medical care. So the process, if a person wants hormones, is finding a provider that will prescribe hormones. And depending on where a person lives in this country, that can be very difficult. And if a person does not have transportation, that is another barrier. And then if they don't have health insurance, or if they do have health insurance, but it doesn't cover the doctor's visit, or it doesn't cover the estrogen or the testosterone or the hormone blockers for the child. So anyway, the process is first, identify the provider, figure out how to get to them. And then there is great variation among providers when it comes to what that provider is going to require in order for the patient to access care. So let's take hormones for adults as an example. So in some parts of the country and in even some parts of our state, if an adult is interested in hormones, some providers require a letter from a mental health clinician stating that the patient meets the World Professional Association of Transgender Health's criteria for hormone replacement therapy. So I want to put that on your radar screen. It's an acronym called WPATH, the World Professional Association for Transgender Health. That is an international body that sets the standards, makes the rules for healthcare. And I put rules in quotation marks because I don't like them. I'm actually a rule follower, and I feel like the criteria from WPATH is really obstructive. It's really problematic. But anyway, we're not here to talk about my personal feelings, I think. The process is finding the doctor, hopefully meeting the criteria for the intervention, and then hopefully getting the intervention like hormones. And then a person has to figure out how they're going to pay for it. The process for surgery is even more onerous because a person will need, if their insurance covers gender surgeries, they're going to need at the minimum one letter for the surgery. Or for some surgeries, primarily those on genitals or reproductive organs, like a hysterectomy or an orchiectomy or something like that, 2 letters from mental health clinicians are required. So then a trans patient has to find mental health clinicians who are able to write a letter, perhaps has experience writing letters, does it right, submits it, doesn't give them a big runaround regarding the process. So getting gender affirming medical care is not like I'm waking up one day and getting everything that I need and want immediately. It's a very challenging process. So in terms of eligibility requirements, I talked about that a little bit, WPATH. When it comes to hormones, here in the Ann Arbor area, and many sort of progressive providers are moving away from the model of making patients obtain a letter from a mental health clinician for hormones. That is sort of falling out of favor, not seen as really an appropriate hoop for people to jump through. So that is a positive improvement, but the insurance landscape is still strongly requiring letters from mental health clinicians outlining that people meet WPATH criteria for gender affirming surgery. And in terms of the requirements for surgery, they're different for each surgery. So for example, top surgery has, I think it's 5 criteria. And then genital surgery for both kind of transmasculine and transfeminine people, I think it's about 7 criteria. And the mental health clinician assesses whether the person meets that criteria, then writes a letter saying, yes, this person meets this criteria. And then there's a chance the insurance company will pay for it. So I hope that's helpful. It's a long answer to a complicated process.
Definitely. So this question was just asking about kind of the difference between pediatric and adult care, I think in terms of access.
Yeah, absolutely. So when we're talking about minors, in order to intervene in such a significant way, changing a person's body in a significant way, such as the changes of estrogen or testosterone, our team at U of M has been notified by the Office of General Counsel that we are to obtain parental support from both parents, not support, consent. The word is consent, Sarah. We need consent from both parents in order to proceed with hormones. So that is a huge challenge in pediatrics because, as you can imagine, there's often one parent who is supportive and there's often one parent who is not. And so long as one parent is saying, no way, I do not provide my consent, we cannot treat that young person with estrogen or testosterone. So in those cases, the supportive parent often tries to work through the court system to obtain full medical decision-making. And we have some parents who are in the process of doing that right now, and I haven't heard status updates recently. It's certainly an uphill battle, and I think there's a lot of variations in the court systems in terms of if you get a judge who is, transphobic or thinks that, a 16-year-old cannot know their gender and should not be on hormones, then this kid is unfortunately unable to access the care that they need until they're 18. So it's probably the biggest challenge in pediatrics. In adult care, of course, adults can consent independently. So that is the big difference in adult care, is that an adult can just make themselves an appointment and get themselves on whatever they need, so long as they can provide consent.
So again, we touched on this a little bit, but if you had some more things that you could talk about navigating insurance versus out-of-pocket costs, is this a big barrier for a lot of your patients?
Yes. Oh, there's so much variability when it comes to insurance. And I'm sure you all know that just in general in healthcare, one insurance provider is going to cover a medication or an intervention, a surgery, what have you. And then the other insurance company is not going to. So same in trans health. But what really gets under my skin is the fact that even today, companies can write into their insurance policies exclusions for trans health services. So I'll give you an example. So what this means is the company, let's just say, it could be U of M. U of M could say, we are not going to cover anything for our employees or the employees' dependents that has anything to do with trans health. So if the diagnosis is gender dysphoria, or if the surgery is a gender surgery, like top surgery or something of that nature, we don't cover any of it. So just last week, I heard of another one of the patients that I had seen. We were checking benefits for Lupron for the kid, puberty suppression. And there is an exclusion in the insurance plan for anything trans health related. And I thought that was illegal under Obamacare, but I could be wrong about that. But it's just devastating. So that is still happening, unfortunately. And a medication like Lupron is many thousands of dollars. So just an average person can't afford that. Estrogen or testosterone is not a big expense. For about a year of testosterone is about $100 out of pocket for a year, approximately. It really depends on the pharmacy. So it might be like $150 or $175 at kind of the most. And estrogen is about $5 a month. So many folks are more able to spend that kind of money. But of course, surgery, if it's not covered by insurance, many average people cannot afford, a $10,000 surgery or a $50,000 surgery. Cost becomes quite a stress for a lot of patients. Especially if the surgery is not covered by insurance, it's just really hit or miss. Sometimes a surgery is covered and sometimes it's not.
So what are some of the ways that we as nurses can help advocate for or provide gender affirming care to trans clients in specialties that aren't specifically dealing with transgender care?
Mm-hmm. Absolutely. There are very significant ways you all can support and affirm trans people. The first thing that springs to my mind is ensuring that you ask an individual what name they want to be called and what pronouns they use. And I would say, yes, do this with everyone. And people kind of roll their eyes and they're like, come on, Sarah, I can't do that with, an 87-year-old grandmother that I'm taking care of. I think it's still okay to ask the 87-year-old grandmother, what name would you prefer I call you? You just never know. Sometimes people use their middle name, or they use a shortened version of their first name, or they want to be called Mrs. So-and-so, or Mr. So-and-so, or Dr. So-and-so. And of course, with trans folks, oftentimes a person will want to be called a name that's different from their legal name. And you might think to yourself like, does it matter that much? I'm really not going to talk to them that often. We're not going to interact a lot. And I'm not really going to use pronouns in front of them. So I'm really busy. I don't have time for this. I would say it's just so important to ask how a person wants to be referred to, both name and pronouns. We get in trouble when we assume things about people, just off of how a person looks. Our gender expression is not always the best indicator for pronouns. There are plenty of people who prefer they, them pronouns and look kind of stereotypically masculine or stereotypically feminine. So it's really important to ask. And then if you hear of another provider or a nurse or an associated health professional who is not calling the patient by the name and pronouns that they go by, another important part of advocacy is saying, oh, you're talking about Jennifer. Oh, you use the name John. Actually, that person goes by the name Jennifer and goes by she and her. And that is an important way of ensuring that a person, the patient, is validated, supported, respected, even if the patient is not in earshot. Sometimes people are in earshot when we think that they're not. And we always want to be respectful and affirming at all times. So using name and pronouns. Other ways of advocating or just being a good human with trans people include not asking too many personal questions. If you're asking questions out of curiosity, that's not a good scene. If you need to know something in order to provide the best medical care to that person, that makes sense. So if you need to know if they're on estrogen or on testosterone for medical reasons, let's say they're on the inpatient floor and you're taking care of them, that makes sense. But, if you're just, I don't know, helping them with an x-ray or something, you don't need to know if they have a penis or not. Or maybe you do. I mean, you all are medical people much more so than I do, but just think about, is your question rooted in curiosity, or is it medically necessary for you to, in the care that you're providing for them? Another long answer from me. I hope that's helpful.
I think that's super helpful, yeah. So what areas of education are essential for nursing students to really understand how to provide care to a transgender or non-binary client?
Let me think about this for a second. I don't know. I'm interested in what Nicole and what you all think about this. I would say all areas of education are essential for nursing students because trans people are just like everybody else. They have the same bodies that need to be cared for. Trans people get heart disease. Trans people need hips replaced. Trans people have, seizures and get in car accidents and need their leg fixed, so I would say it's kind of like general healthcare plus knowing about the unique experiences of being victimized in the world, being stigmatized, being discriminated against, both out in the world and in the healthcare setting. So I've worked in trans health for about 12 years now, and I have heard story after story after story from patients about feeling like the medical provider saw them as a freak or a weirdo or gross, repugnant, feeling like the provider was taking extra precautions, didn't want to touch them, made all kinds of assumptions about their identity and sexual behavior and partners. And you might think to yourself, like, oh my goodness, Sarah, no, we're in Ann Arbor, Michigan. It is 2021. You know, more people have been exposed to trans people, and there's some demystification about trans people. Yes, things are getting better, especially in cities like ours that are kind of more progressive, but not everywhere is like Ann Arbor. And you all might sort of leave Ann Arbor at some point and go to places where there's more othering of trans people, less comfort with trans people. And it's important to just treat trans folks like you would anybody else. That's my 2 cents, but I'm wondering if Nicole has any thoughts on this, or Charlie, if you do, or if anyone else on the call has thoughts about this.
I think you really hit the nail on the head there, that we really just need more of an understanding that trans people have other health conditions, that they don't come in the hospital necessarily because they're trans. They probably don't. They probably come in for something else. And so just being able to advocate for their needs and make them feel like they belong and that we are there to support them while also helping them with their medical care. Nicole, did you have anything you wanted to add about that?
I think you both summed it up so beautifully. I think that what we don't want to do is to further ostracize people and make people feel othered even more. And I think, Sarah, what you said was so beautiful about understanding unique experiences that trans and non-binary folks go through, and how we can lessen the harm that they feel or may have felt historically, and how we can, I always say, as nurses, our roles are to be advocates and to meet people on their healthcare journey as their unique selves, mind, body, and spirit. And if we could stop categorizing people and just really meeting them for who they are, we can provide the best care for them. And I think that we do need, like, that overview, Charlie, that you gave at the beginning, and kind of some of the topics that Sarah has spoken about, how do we describe gender identity, sex assigned at birth, those type of things, to kind of know the functionality of things. Other than that, we're all humans. We all have this beating heart and a brain. And so, that's what cut across. So that common humanity is so important, I think.
Thank you, Nicole. So we have a little story here that will lead into our last question, and then we will have some time for Q&A from everyone who is attending. So I will just read this out for you guys. It says, I was caring for a transgender patient as a nurse tech on nights. This was during the peak of the COVID pandemic. She was on end-of-life care, so she was able to have 2 visitors and 1 overnight. Her mom stayed in the room. This client could not speak or move independently, but was fully conscious and aware. Throughout the shift, her mom consistently misgendered her while in the room with her, even when the nurse and I used the correct pronouns. I felt horrible for this woman. She was dying, and the last words she might hear would be her own mother's disrespect. I brought it up to the nurse, and after some pushing, she agreed to talk to the patient's mom. She asked if the mom knew the client was transgender, and the mom simply said, yeah, her dad and I just never got used to it, I guess. We never called her that. After this, the topic was dropped. So Sarah, if you could just talk to us a little bit about how to advocate for our patients when we notice this kind of behavior. And you did touch on it a little bit before, which was fantastic. But I know we have a lot of students here, and they sent in a few questions about how this might vary when talking to a preceptor, which is someone who's like our instructor on the floor. So there's kind of a power imbalance there, and a lot of students were saying it's hard for them to address it in that way. So we'd just love to hear your thoughts on that.
Yeah. Would you actually mind going back one to the little vignette?
Yep. Tight.
So I just want to clarify, because I realize that some folks might have some questions about what's written here. And I'm just going to tell you some assumptions that I'm making. So I believe that this patient is probably a transgender woman. So assigned male at birth, probably identifies as a woman in she, her pronouns. So the person writing this is using the correct pronouns, saying she. My hunch is that the mother was using he, him pronouns. So mom was saying he, him, my son, etc. Yeah, I just want to make sure that folks are understanding. And then there might be folks on the call who are like, what does misgendering mean? So misgendering is when a person is not called the pronouns that they go by, not being called the name that they want to be called. So I just wanted to define that as well, in case there were people who were like, what are we talking about here? Okay, so now I can go on to how do we advocate? So I think the student who posed this question handled this beautifully by saying to the preceptor, I believe, like, hey, we gotta do something about this. Like, we have to talk to the mom about, like, do you know that your child uses she, her pronouns? So I understand the power differential, but I think that even a student and preceptor relationship, there is an opportunity to approach situations like this with curiosity. So the student could say to the preceptor, oh, I'm noticing that the mom isn't using she, her pronouns for this patient. What are your thoughts, preceptor, on how we should handle this? And then the preceptor could give their thoughts. And then if the student thinks like, oh, that's not a good thought, the student could say, oh, well, I was wondering, how would you feel? Could we possibly together, or do you feel comfortable just going in and just asking mom about this? So approaching a conversation from a curious questioning, I'm wondering if XYZ might be okay kind of stance, rather than, oh my goodness, this is ridiculous, we've got to do something about this. Like, just a gentler kind of approach. And I think that's what the student did in this situation. And it sounds like that approach was successful. But then it was successful to a certain degree, right? Because the nurse opened up this conversation, like, do you know that your child uses she, her pronouns? And the mom was like, yep. And then it just kind of fell apart from there. So what to do then, right? So I think at the end of the day, we can't make other people do things. We can lead by example. We can use our own behavior to inspire other people. So we can keep calling people the name that they want to be called and the pronouns that they want to be called, and respectfully encourage others to do the same. And that includes other nurses, that includes doctors, etc. Nicole, do you have thoughts on this? Because you're someone who's been in the trenches and interacted with unsupportive family members and unsupportive other healthcare providers. Do you have thoughts on this too?
I think, I would echo what you say. I think that the student did an amazing job at that point in time with a very complex situation. And I totally, wholeheartedly love the approach with curiosity in complex situations. I think that it disarms people. They expect a fight. And if we can open up with curiosity and compassion, even though we are getting, maybe activated ourselves, that starts changing the dialogue a bit. And my experience with families, I don't think I said this, but my background is I worked on the child and adolescent psychiatric unit for 13 years. We had lots of kids who were, exploring various areas of their sexuality and gender identity, and various parents on various areas of acceptance. And we would start digging into it a little bit with the parents. And, what I would hope from that nurse, if I could give feedback to that nurse and that experience, is there an opportunity to continue that conversation, to continue modeling that behavior, but also perhaps offering some perspective taking for what's happening for their daughter at this point in time. The fact that their daughter is dying, and how much this really means to people, and just continuing that conversation to try to build rapport with that family in a curious, compassionate way, not in a judgmental way. Because if we get judgmental with people, they dig in and they become defensive. And so it's that curiosity and compassion that can really change people's minds. So it's a difficult situation, but I always say, choose the curiosity and compassion and advocate for what you know is right.
Thank you so much, Nicole and Sarah, for your fantastic answers. So we have some time for questions, so feel free to unmute or throw them in the chat. We'll hang tight for just a few minutes to see if anyone's got anything to ask. And then we will close with just some resources for you guys to take away from this. So I'm going to share those resources, and then rather than unmuting, just throw questions in the chat and we'll address them as we go. We've got a question here from Jessica. It says, can you speak to what would be most appropriate with inpatient rooming? My experience is we try to get a private room when possible, but that isn't always an option.
Oh boy, I was in a lot of meetings about this. A lot of meetings. So when I was in meetings about this was about a year and a half ago, a little more than a year and a half ago. This was a bold move on U of M's part, but we have an anti-discrimination statement, an anti-discrimination policy that I am so proud of our institution. And there, I think with the ACA, there were some added instructions to healthcare institutions, hospitals like ours, that said you need to really amp up your anti-discrimination efforts and equity in the healthcare system. And so we changed our rooming policies, where we have explicitly added that people can be roomed consistent with their gender identity. So if a person identifies as a transgender woman, she can have a room with a cisgender woman. If a person identifies as a trans man, he can be roomed with a cisgender man. And a non-binary person can choose a roommate sex that feels right to them. So then the meetings the next question was, okay, what do we do when the cisgender roommate, if the cisgender roommate has a problem with that? Like, this person is not a woman, or this person's not a man. And what do we do then? So the plan is that the patient who's complaining is moved. So is that what is actually happening? So in other words, we don't move the trans person out. The trans person is not the problem. The person complaining would be moved. Is that what's actually happening on the floors? I am less aware of what is actually happening. My impression is that single rooms are still trying to be obtained for trans people. But as we all know, we have very limited single rooms. So then I'm not up to date regarding what exactly is happening on the floors. I love your questions. Thank you.
Yeah, that was a great question. Yep, we do have a comment here from Jessica. It says that her only experience is with trans patients in single rooms. Okay, so we will continue to get questions in the chat, and I'm just going to share the couple of resources we have. So a little slide here, just summing up all of the great points that Sarah's already made about some of the steps that you can take, asking name and pronouns, educating yourself and others, and of course, advocating for your patients. So this was a cool thing that's upcoming in September that I just wanted to share. And it is from the Columbia School of Nursing. They are actually offering a certification for nurse practitioners who are in their master's program on providing transgender care. And that's a new program that's starting in September. So it'll be really cool to see kind of what happens with that and what people learn and how it changes the future of trans care. And then this is an upcoming event that just wanted to promote to you guys. It's called Trans Talks by Stanford University. It is upcoming in a couple of days, and it is going to be talking about providing cervical cancer screening to trans masculine and gender non-conforming individuals. So sounds like it should be super interesting. It is at 9:30 p.m. Eastern time, which I know is quite late for a lot of us. So it will be recorded. So if you go to that link and register, they will send you the recording. So if you're interested and you're not a night owl, I'm certainly not, you can still register and they will send you the recording of the event. Going to move. We just got some special thanks here, and we got a couple more questions in the chat for you, Sarah. So Max asks, per recent legislation passed in Arkansas, I was wondering if you could touch more on the importance of children and adolescents being able to access gender affirming care.
Oh, wow. Thank you so much for that question. These are devastating and heartbreaking times for families of transgender youth across the United States. Even if kids are not living in Arkansas, you know, just yesterday, I had a mother say to me, what if what happens in Arkansas happens here? And of course I thought about that. Oh God, it just feels so heavy because this is the work that I do all day, every day. And these young people cannot be without this care. You know, we can't not provide gender affirming care to young people. It's just not an option. The care that we are providing to people saves lives. Young people are attempting suicide and completing suicide when they are not able to access care. This is an emergency. It is essential. It is medically necessary. We are in a position right now in Michigan where our governor would veto anything of this nature. But then, so I said that to the mother the other day, and the mother said, well, isn't she up for re-election in a year or something like that? And then the mother said, oh, well, my kid is 17, so my kid would be okay because then he'll be 18. But then there are all these other children, and what are we going to do? So, you know, the absence of listening to doctors and medical professionals and science is very scary, because there is tons and tons of data and research outlining the effects of gender affirming medical care on youth, positive effects. And the fact that that could all be ignored is really scary. So don't be surprised if you hear that kind of anxiety from parents and families in Michigan, because I'm certainly hearing it.
Yeah, and I thank you, Max, for bringing up that question. I think that I was just hearing a couple days ago about California looking at similar legislation. It's definitely making its way around, which is very scary for parents and kids.
Very scary.
I think that is all the questions that we have. So I just want to thank you again, Sarah and Nicole, for joining us for this event. We are so grateful to have you, giving us just absolutely priceless information. We do have here our interest form. So again, for everyone who came today, we are so happy that you were able to make it. And we just ask that you fill that out before you head out, so we know exactly what the interest is for events like this in the future.
Thank you all so much for your interest in this area, and keep learning about trans folks and being awesome nurses.
Thanks so much, Sarah.
Great job, Charlie.
Thank you.
Thanks.